Welcome to this lecture on shoulder and upper arm pathologies. The shoulder gives athletes a huge range of motion for throwing, reaching, blocking, lifting, swimming, serving, and tackling. But that mobility creates a constant stability challenge. As we move through the lecture, think in clinical patterns. Lateral pain with resisted elevation suggests a different path than a traumatic slipping sensation. Top of shoulder pain after a fall, or deep clicking in a thrower. Your job is to connect history, mechanism, observation, motion, strength, and selected tests to the tissue most likely involved and the level of urgency. These objectives are our roadmap. First, we will look at how the shoulder balances mobility and stability through the glenohumeral joint, scapula, clavicle, rotator cuff, capsule, labrum, and kinetic chain. Then we will compare common patterns: cuff-related pain, subacromial pain, instability, labral symptoms, AC joint injury, clavicle injury, and biceps involvement. The goal is not to memorize one test for each diagnosis. The goal is to ask better questions, recognize concerning findings, and connect the exam to rehab and return to sport decisions. Use this anatomy slide to orient the shoulder complex. The shoulder includes the glenohumeral joint, scapulothoracic articulation, AC joint, sternoclavicular joint, labrum, capsule, clavicle, rotator cuff, and surrounding neurovascular structures. A problem in one area can change load somewhere else. Before naming a diagnosis, map the symptoms. Is the pain lateral, anterior, superior, deep, posterior, or radiating? Then connect that location to the mechanism and task, such as throwing, falling, lifting, or contact. The subjective exam separates shoulder complaints into useful patterns. Ask whether symptoms began after trauma, repetitive overhead load, gradual overload, or an instability event. Then listen for night pain, weakness, clicking, catching, dead arm feelings, inability to throw, or episodes of dislocation or subluxation. Also ask about hand dominance, sport demands, prior injury, surgery, cervical symptoms, numbness, and tingling. A shoulder that feels like it slips is not the same clinical story as a shoulder that simply hurts overhead. Observation and basic objective testing guide the rest of the exam. Inspect shoulder contour, clavicle alignment, AC prominence, scapular position, muscle bulk, bruising, swelling, resting arm posture, deformity, sulcus, winging, or fear with movement. Compare active and passive flexion, abduction, internal rotation, and external rotation. Active motion shows what the athlete can control, while passive motion helps separate pain, stiffness, guarding, and structural limitation. Strength testing should include the cuff, deltoid, scapular stabilizers, and movement quality during elevation. Choose tests based on the question you are trying to answer. Lateral pain with overhead activity fits painful arc and resisted cuff testing. A slipping sensation or apprehension in abduction and external rotation fits instability testing. Deep pain with clicking or throwing loss fits a labral and biceps cluster. Top of shoulder pain after contact fits AC palpation and cross-body adduction. If there is traumatic deformity, severe weakness, suspected fracture, dislocation, or neurovascular symptoms, stop broad provocative testing and prioritize protection, screening, and referral. Now we are moving into common shoulder disorders. Keep in mind that these conditions can overlap. A thrower may have cuff irritation, scapular control deficits, posterior shoulder tightness, biceps irritation, and labral symptoms together. A collision athlete with instability may also have cuff weakness or apprehension. For each condition, listen for the pattern. Where is the pain? What mechanism created it? What movements reproduce it? What findings raise concern? And what early management is safest? Rotator cuff-related shoulder pain often presents with lateral shoulder pain, weakness, or pain with overhead activity and resisted testing. Symptoms may appear with throwing, serving, lifting away from the body, or sleeping on the involved side. The cuff helps center the humeral head on the glenoid, while larger muscles create motion, so reduced cuff capacity can make elevation painful or inefficient. Examine active motion, painful arc, resisted external and internal rotation, resisted abduction, scapular control, and overhead tasks. Rehab emphasizes symptom-guided loading, cuff strength, scapular control, and gradual return to elevation. Subacromial pain should not be explained only as a tendon being pinched. A better model considers tissue capacity, irritability, scapular mechanics, cuff control, thoracic posture, training load, and overhead demand. Athletes may report pain with mid-range elevation, reaching, pressing, lifting, or repeated throwing. Examine painful arc, resisted cuff testing, scapular motion, thoracic mobility, and the specific task that reproduces symptoms. Early care usually reduces painful overload, restores comfortable motion, improves cuff and scapular strength, and rebuilds overhead tolerance gradually. Anterior instability commonly follows a traumatic abduction and external rotation mechanism, but it can become recurrent in collision or overhead athletes. The athlete may describe a dislocation, subluxation, dead arm sensation, slipping, shifting, or fear in vulnerable positions. In acute cases, assess deformity and neurovascular status first. Later, apprehension, relocation relief, increased translation, and guarded motion help support the pattern. Rehab must build dynamic stability, cuff and scapular strength, proprioception, and confidence. Recurrent episodes, persistent apprehension, or suspected labral injury should prompt referral. Labral pathology and slap lesions often present with deep shoulder pain, clicking, catching, popping, instability feelings, or reduced throwing velocity and control. Throwers may notice symptoms during late cocking or follow-through because the shoulder experiences high torsional and deceleration loads. The superior labrum connects closely with the long head of the biceps, so symptoms can overlap. No single test confirms a labral injury. Combine history, sport demand, mechanical symptoms, ROM, strength, instability findings, and clustered tests. Persistent mechanical symptoms or performance loss may require specialist input. AC joint sprains and clavicle injuries usually follow direct trauma, such as a fall onto the lateral shoulder or a collision. AC injury often creates focal top-of-shoulder pain, local tenderness, swelling, pain with crossbody adduction, and sometimes a step deformity. Mild sprains may need protection and gradual return, while higher-grade injuries require referral. Always consider clavicle fracture when trauma causes deformity, severe pain, crepitus, skin tenting, or difficulty supporting the arm. In acute trauma, visual inspection, palpation, neurovascular screening, and protection matter more than broad shoulder testing. Long head of biceps pathology often causes anterior shoulder pain near the bicipital groove. Pain may increase with resisted shoulder flexion, elbow flexion, supination, lifting, throwing, or overhead activity. Because the biceps attaches near the superior labrum, biceps pain can overlap with cuff and labral problems. Examine groove tenderness, resisted supination, resisted flexion, shoulder ROM, cuff strength, and labral signs when indicated. A sudden pop with bruising or deformity may suggest rupture. For chronic irritation, management usually includes load modification, progressive strengthening, and cuff and scapular work. This section pulls the conditions together. The question is not only which diagnosis sounds most likely, but which pattern best explains the athlete's symptoms and risk. A shoulder that feels unstable in abduction and external rotation is managed differently than pain with resisted external rotation. Deep clicking in a thrower is different from focal AC pain after a fall. A visible deformity after trauma shifts the plan toward protection and referral. Return to sport must match the condition. Overhead loading for cuff pain, stability for instability, throwing progression for labral symptoms, and contact tolerance for AC injury. Use this matrix as a quick clinical organizer. Cuff-related pain usually involves lateral pain, overhead weakness, painful arc, and resisted cuff pain, with progressive rehab as the usual direction. Instability includes slipping, apprehension, dead arm symptoms, and positive apprehension or relocation patterns. Labral pathology often includes deep pain, clicking, catching, and throwing performance loss. AC injury is focal top of shoulder pain after impact. Trauma with deformity, severe weakness, or neurovascular change belongs in the urgent referral category. In this case, the volleyball player reports repeated slipping when the arm is abducted and externally rotated. That is the key detail. This is not just overhead soreness, it is an instability sensation in a vulnerable anterior shoulder position. Apprehension during testing supports anterior instability. Ask about prior dislocations, subluxations, frequency, need for reduction, and worsening symptoms. Screen cuff strength, scapular control, RAM, and neurovascular status. Rehab should emphasize dynamic stability, proprioception, cuff and scapular strength, and gradual return to serving, hitting, blocking, and overhead reach. In this case, the athlete falls directly onto the lateral shoulder and develops focal superior shoulder pain, swelling, and visible prominence near the AC joint. The mechanism, location, and contour change make AC joint injury the leading concern, but clavicle fracture must stay in the differential. Examine with inspection, AC and clavicle palpation, neurovascular screening, and gentle functional assessment. Avoid excessive stress in the acute setting. Refer for obvious deformity, suspected fracture, skin tenting, neurovascular symptoms, severe functional loss, or higher-grade AC injury. Shoulder management should move from safety and symptom control towards sport-specific capacity. Atraumatic deformity, suspected dislocation, fracture, neurologic change, or high-grade AC injury needs protection and referral. Less irritable overuse conditions may tolerate earlier mobility and strengthening. Rehab should restore pain-controlled motion, cuff strength, scapular control, trunk contribution, and kinetic chain integration. Overhead athletes need throwing, serving, or pressing progression. Collision athletes need contact tolerance and confidence. Return requires strength, stable motion, symptom control, movement quality, and task tolerance. The main takeaway is that shoulder evaluation is strongest when anatomy, mechanism, and function are interpreted together. The shoulder is rarely a one-structure story. The cuff, labrum, capsule, scapula, clavicle, cervical spine, and kinetic chain all influence symptoms and movement. Do not overtrust one special test. A painful arc, apprehension test, crossbody adduction test, or labral provocation test matters most when it fits the history. Ask good questions, respect traumatic red flags, choose purposeful tests, and progress the athlete toward the actual demands of sport or activity. These references support the shoulder anatomy, examination principles, rehabilitation concepts, and clinical reasoning used in this lecture. Use them to review scapular mechanics, rotator cuff rehabilitation, shoulder instability, special testing, and return to sport concepts. Evidence-based care is not just memorizing citations. It means comparing the best available information with the patient's story, the exam findings, the sport demands, and the safety of the situation. As you study shoulder conditions, keep asking what tissue is involved, what load exposed the problem, and what capacity must be rebuilt.